Hello, everyone. Thank you for joining. Just as James is pulling up the slides there, we're going to get started, and people can join us as they're rounding up from their lunch. Just to get started with a little bit of introductions. So my name is Shannon Rockall. I'm an occupational therapist. I am the Regional Clinical Liaison for Praxis Spinal Cord Institute. I also work as a clinical OT with Access Community Therapists in spinal cord injury, and have been doing, haven't been with Access for 25 years, but I have been working in spinal cord injury rehab for the better part of 25 years. I work together with my colleague James, who is working the slides for us today. And James, do you want to introduce yourself, or would you like me to do the introduction? Okay, so so James is BC Regional Community Liaison. He lives with spinal cord injury for the last 27 years. And he is the president of Accessible Okanagan as well. And him and I have the pleasure of working together at Praxis, providing workshops around the province on spinal cord injury to clinicians, primarily in the regional and rural areas of BC. So we started this webinar series in collaboration with GF Strong, just because when we would go out to the different communities, we were getting so many questions about the services at GF Strong and just needing more clinical information. So a lot of our workshops that we do, they are in person, and we figured that we could reach a wider audience doing them virtually. So we've started this series. This is the third one, and we've been doing them about, well, every 6 weeks or so. We're still trying to work on the exact schedule, and it's coordinating a whole lot of details. But we are trying to bring together our communication so that more people know about it, more people are able to attend. I believe we have 230 registered for today's webinar, which is fantastic. If anybody is not able to stay for the whole time, please feel free to review the webinar. We'll be sending out the recording in an email following up. We have two dynamic presenters today. We have Cynthia Morin, who is an OT, advanced practice OT and spine educator at GF Strong. We also have Spring Hawes, who is a person with lived experience and the Regional Plex Engagement Liaison with Praxis Spinal Cord Institute. So we're going to be hearing about the clinical and the lived experience. Before we move on, just wanted to let you know that you can use the chat if you have questions, and we'll do the presentation, and then we'll leave some time for questions at the end. Also wanted to acknowledge that we are joining today from the Silk Okanagan Nation, that we are so grateful to be able to live, work, and play. And just actually reflecting on what that means, right? This land that we have the amazing opportunity to be a part of. I'd like to know if you would like to share where you're from. Please feel free to put it in the chat, and we can acknowledge the broad community that we're joining from today. So we're going to be implementing Slido. Bit of interactive polling through the webinar today. If you could pull out your phones or join at your computer with the QR code or the link that you see below, that would be fantastic. We just have a couple questions. So which health region are you joining us from? Island Health is representing. Nice. Thank you, Gabe, for acknowledging that. Gabe, are you able to let us know from where you're joining? Sorry. So Fraser Health. Excellent. Okay, so we have a large representation from Island Health, which is fantastic. Interior Health, Vancouver Coastal, Northern Fraser. Okay. Fantastic. So which discipline or role best represents you? Okay. Large number of OTs and PTs. Good to see wide representation. Okay, so nursing, excellent. We'd love to see the nurses joining for these sessions, particularly today's session on pressure injuries. Okay. Where along the continuum of care do you work? Okay, so large number from our acute care, leading community health. Okay, rehab, long-term care, non-clinical, and then intensive care in that order. Excellent. Thank you so much. So we are going to get started into the session, which is spinal cord injury, pressure injuries, prevention and management. And I'm going to pass it over to you, Cynthia.
Okay, well, thanks everyone for coming today, spending some time with us. I will fully admit that this is the largest group I've ever presented to. So if you hear my voice shake a little bit, it's because I'm a little bit nervous. But here we go. So I have worked in spinal cord injury for about 15 years. A large portion, unfortunately, of my caseload is working with people who have pressure injuries. And so I was happy to share some of my knowledge and experience, if that can help anyone else's practice out. So a lot of what I'm going to talk about today, I'm really hoping that some tidbit of information will help with your individual practice. It was really difficult to figure out what information to include because there's such a wide range of professionals, disciplines who work across the continuum of care. So my hope is that over the next 45 minutes, I'll be able to equip you with some information that you can then take back into your practice. So the objective of today's session, there's going to be a lot of information that I'm going to run through. Please don't concern yourself with taking notes or copying the slides. I believe this presentation is going to be posted up, so you can always review it at a later time. A lot of what I will talk about will be about the assessment process because the information hopefully can be applied across the continuum of care, whereas interventions tend to be more specific to the individual. Also, doing a thorough evaluation provides you with a good roadmap to whatever interventions you'll then move forward with. So why are we talking about pressure injuries? So if you can move just to the next slide. I pulled up some quick facts that give a little bit of understanding as to why this is such a significant issue for the SCI population. As you can see, there's a high rate of occurrence. It can be a cause of premature death, and there is a significant burden on the healthcare system to treat pressure injuries. So it is quite a significant secondary health issue for the spine population. And so when we talk about pressure injuries, I'm going to try, if you can move to the next slide, please. The term pressure injuries, you'll probably hear me use pressure injuries and wound kind of interchangeably. Pressure injuries is the most current terminology for describing these wounds. The term comes from the National Pressure Injury Advisory Council, the NPIAP, which is a U.S. organization. And that's the NPIAP is basically the authority on any type of wounds or pressure injury. So they changed the terminology from pressure ulcer to pressure injury in 2016 to more accurately include stage 1 pressure injuries in the terminology, because at that time the term ulcer denoted an opening in the skin, which does not capture stage 1 wounds. But as you can see, I put up some other terms there. Pressure injuries is often not used in the language and documentation, and so it can be any of these descriptors that you may come across. And just so we can have a quick refresher, if you can move to the next slide, let's have a quick reminder of what we're talking about here. A stage 1 pressure injury is ideally when we want to intervene, or even before, preventing any pressure injuries from happening. At this stage, stage 1, healing can usually occur in days or weeks with less intervention, whereas at stage 3 or 4, wounds can often take months or years to heal, require increased care, equipment changes, and may not heal with conservative measures. So surgery may be required to close the wound. So with the next slide, it's just a really quick overview of my experience that the incidence and severity of pressure injuries tends to be correlated to the level of injury and the completeness of the spinal cord injury. In other words, the higher the level of injury and the more complete the cord injury, the greater the incidence and severity of pressure injuries. Now, why would that be? The primary reasons are reduced sensory feedback or discomfort, reduced ability to weight shift, increased reliance on equipment. So it's a problem if the equipment that the client has isn't working as it needs to, and increased dependence on support people. But that's not to say that incomplete injuries or lower level injuries aren't at risk for developing pressure injuries, because they definitely are, even people who ambulate. I actually worked with one woman who had a significant coccyx wound for about 5 years, and she ambulated as her primary method of mobility. But she didn't have any sensation in the area of her wound, so it often was not treated appropriately. She did end up requiring surgical closure of her wound and spent a month in hospital recovering after the surgery, so it was quite significant for her. As I'm sure many of you are aware, there are also many non-medical factors that increase the incidence and severity of pressure injuries, and there are many more than what's listed on this slide. And the unfortunate reality is that there is a discrepancy in healthcare services, which can affect the incidence and severity of pressure injuries. For example, it's not uncommon for GF Strong to admit people from rural communities who have a pressure injury simply because there aren't sufficient medical and allied health services to support the client in their community. Okay, next slide, please. So as the pressure injury stage increases, the greater the impact on multiple areas, including, and most importantly, the client's quality of life, but also increased healthcare costs, increased negative health outcomes, increased negative functional outcomes, which is often related to deconditioning, which is caused by long periods of bed rest, deterioration of mental health and cognition. I mean, I was quarantined for 5 days when the COVID pandemic first started, and I found that very challenging on my mental health because I wasn't able to engage in my normal daily activities. Now imagine the impact that months of bed rest can have on an individual's mental health because of a pressure injury. Now at this time, I think it's a good time to invite Spring to give her discussion on lived experience with a pressure injury.
Thank you, Cynthia. And hi, everyone. My name is Spring. Like Shannon said at the beginning, I work for Praxis. I have a spinal cord injury, and I've just been invited to share my own sort of personal journey with pressure injury as a part of this presentation. And so I will try to keep it as concise as possible. On the screen is a journey map that we created as part of a qualitative research project recently that sort of arose out of my experience navigating the healthcare system with my spinal cord injury and my pressure wound. So I know it's kind of small on the screen, but I think we can send it out to you later if you're interested in it. But it just sort of demonstrates like the complexity and the challenges of that whole journey. Mine was almost 2 years long. So in about 8 years ago, it was in August, and I have attendant care because I'm a quadriplegic. And so one morning, my personal attendant, she just commented that it looked like I had some redness on my sort of my IT areas. And it was summertime, and I'd been in the lake and floating in a tube and that sort of stuff. And I thought, oh, it's probably just some bruising, you know, it's not a big deal. But I sort of kept track of it, and it was still there a couple days later. So I had it assessed by a community nurse who just said, oh, just put a Band-Aid on it, it'll be fine. And so that's what I did, but it didn't get better. And so a week or so later, I went in again and asked for an RN to look. And this time it was really evident that I had pressure injuries. And so they started coming to my home every couple of days and doing a dressing on my IT area, and not really treating it as something that was really concerning to, you know, overly concerning. And from my perspective, I was really going off of the information that I was getting from the caregivers. And so I knew that it wasn't good, but I did not have a full grasp of, you know, what was really going on, because I can't see it, I can't feel it. So I'm going by what people are telling me. But this went on until November, and by then I was pretty sick, and I still hadn't really connected the severity of and the impact of that wound on my actual health. Like I don't think I had a full real grasp on how massive it had become. But I was really sick, and every day I would get up and then I would go back to bed because I was so sick. And I was still having nursing coming every couple of days, and they were doing their thing and changing their, you know, trying different approaches, but that was it. There was nothing more. It was just putting dressings on. And so I just began to feel really desperate because things were digressing badly, and there didn't seem to be a lot of reaction to that. So I actually ended up calling a friend of mine who was an OT who worked it's a small rural hospital where I lived, and she worked in the hospital and in community. And I called her. She was just a friend, and I just called her as a friend and said, I'm really sick and I need someone to help me figure out what is going on and to intervene. And so she came to my house right away, and she was just, you know, kind of stunned at how I looked and just that I was really clearly sick. So she, you know, talked to some people at work, and I eventually was called in and met with my doctor in the ER, who did an assessment. He had not done an assessment, and apparently there hadn't been any communication between him and the RN who was in charge of my wound, which I, you know, in hindsight, I should have known, but didn't realize at the time. So I was sent to get to meet with an orthopedic surgeon because they needed to have a full assessment of the wound and how much it had progressed. And my doctor had wanted to get a bone biopsy for some reason before starting any sort of antibiotic treatment, and keeping in mind that I was progressively getting sicker and sicker, and by this time I was on bed rest. So I had to travel about an hour and a half out of town to meet with the orthopedic surgeon. And when I got there, I just asked that before he went ahead with the biopsy, that he examined my wound, and I shared with him that I was really frightened because I just didn't feel like the care that I was receiving, well, it clearly wasn't. I'd started out with a small wound, and it had progressed to be, making me actually sick. So the orthopedic surgeon examined me and diagnosed me on the spot with osteomyelitis. He had a PICC line inserted like in the moment there at the hospital while I was at the appointment with him, and had me admitted to my local hospital when I went home. So this was, an emergency situation that had not been picked up by my local healthcare team. And that was kind of the beginning. I spent 6 weeks in the hospital on intravenous antibiotics to clear the infection up. And I went home for a couple of weeks over Christmas, and it became infected again while I was at home, and I was admitted into the hospital. And I started to feel the severity of this, that without having some sort of significant intervention and change in care, I was at very high risk of dying from sepsis, of this wound becoming infected to the point where I wouldn't heal from it. So I actually made a decision to move, to relocate. And I did that while I was on bed rest and having a stage 4 pressure wound. And I bought a house and I moved to Kelowna. And once I'd gotten here, and that's a whole other story, that whole process, but once I got to Kelowna, I was able to get, more, I think, just more expert care. People were, that I, was in touch with, the community nursing, were really experts in pressure wound care. And my wound did stabilize. So I wasn't sick anymore, but my wound wasn't healing. So this was now leaping all the way forward to September. So I've had this wound for over a year. I'd been on horizontal bed rest for over 10 months. My wound was stabilized, and the healthcare team seemed to be pretty comfortable with just having me come in every other day and getting a wound change. But there wasn't any urgency around actually resolving that wound. And it really started to feel like this could just go on indefinitely. What I missed saying at the beginning is I'd been advocating to be referred out to a plastic surgeon right from almost the beginning of finding out the extent of the wound, and just had been hitting a lot of barriers in getting that referral out. But once that wound had stabilized, I asked again, to be referred, and I was able in November of which would have been a year and a half later. I was able to get referred, and then in March, which would be a full 18 months, I did have successful flap surgery and a bone reduction on my ischial, my right ischial. And I spent 6 weeks in hospital in Vancouver, 3 at VGH and 3 at GF Strong. And, it's resolved. It's never returned. Everything is good. My surgery is healthy and strong, and I'm back on the road. But I guess that some of my observations are just from the start to the end. That journey lasted 20 months, and I had over 300 medical appointments, and I spent 10 months in my bed. It's the only time in my experience that my grown children cried when they saw me. And then my other just takeaway from that, when you have a traumatic spinal cord injury and you're in the acute stage, and there's a lot of urgency and focus on, getting you up, getting you active, getting you strong so you can do transfers and you can spend time in your chair and you can get back to, living your life in the community to the best that you can. And that felt absent in my experience of a pressure wound. It felt to me that people were quite content to let me have that wound indefinitely. And I just felt the anxiety and the stress and the fear of becoming infected and dying from that wound every single day for the whole 20 months. So it was not just the lying in bed. It wasn't just the bed rest and being unable to participate in anything, but it was that layer of anxiety and fear and stress. So that's my story. It's a tough one, and I hope that by sharing it, we can sort of understand and find ways to keep that from happening to people in the future. Thank you.
Okay, thanks so much, Spring, for sharing your experience with us. That sounds like it was quite a very, very difficult time for you, and it's very unfortunate that that was your experience. So let's kind of switch back to, let's talk about some of the causes, primary causes of pressure injuries, which I'm sure many of you know: pressure, shear and friction, and moisture. So excessive pressure doesn't allow the skin to get oxygenated blood circulating in the tissues. If you think of it as a garden hose that's being kinked, as blood is prevented from bringing oxygen and nutrients to the skin and removing carbon dioxide and waste away, the skin begins to die, which can result in a pressure injury. Pressure injuries can begin at the surface of the skin, or they can also begin deep inside the tissues and then erupt on the surface of the skin. So the skin is actually the most pressure resistant surface of all the body tissues. Muscle, because it's so metabolically active, can start to have problems more quickly than other tissues. So that's why it's possible for muscle underneath the skin to be damaged while the skin above is still intact. So those are those types of pressure injuries where you may see some changes in the skin color, changes in the temperature of the skin, changes in the way the skin feels. If it's a little bit softer, kind of boggy, sometimes is what it's described as. That can be a pressure ulcer that's waiting to present itself. It's estimated that it only takes between 1 and 6 hours of constant low pressure that can cause damage to skin tissue. There can also be recurrent pressure, such as frequently bumping an elbow against a table or a desk or an armrest multiple times a day, that can result in tissue damage and a pressure injury. Or it can be short periods of high pressure, such as accidentally hitting a hard surface when doing a transfer. Shear and friction can also be a cause of pressure injuries. Although these terms are different, you'll often hear them used interchangeably. It's quite difficult to distinguish between shear and friction when you're looking at a wound. And then there's moisture, of course. That's when skin is exposed to moisture for extended periods, and the skin can become macerated, weakened, and vulnerable to breakdown. So common sources of moisture in the SCI population is urine, feces, and sweat. And quite often pressure injuries can be a combination of these causes. Okay, next slide. Let's talk about some primary risk factors. So I've already touched on them a little bit, but they're worth repeating. The 3 primary risk factors are sensory loss, reduced mobility, and moisture. Like Spring had mentioned, she couldn't feel her pressure injury. So it's really hard to make a connection with such a significant health issue when you really have no sense of it. That being said, there's also a whole host of additional risk factors that need to also be considered, such as aging with a spinal cord injury, length of the injury. As the longer a person has a spinal cord injury, the collagen and muscle tissue decreases with age and time, which makes the skin more fragile and less durable to external forces. Tobacco use and smoking, it reduces the blood flow to the skin, which makes the skin more susceptible to damage from pressure points. Impaired cognition. So it's my clinical experience. I have no evidence to back this up, but it's my clinical experience that, in particular, when the mechanism of injury for spinal cord injury has been a trauma, A concussion can also be a missed diagnosis. And so the focus is on the spinal cord injury because that's the most pressing health issue. But if there's an undiagnosed or underlying mild brain injury, then that can cause difficulty with learning or implementing skin health management practices. Spasticity can also be a risk factor, which can cause shear and friction pressure injuries. Substance use, so altered level of awareness, can cause problematic positioning and can be a barrier to implementing skin health management practices. And then poor nutrition. So if the body doesn't get the calories, protein, vitamins, and minerals that it needs, then it can weaken the skin, again, making the skin more susceptible to pressure. Next slide, please. So here's a few terms that you may hear along the way. Spring had mentioned her battle with osteomyelitis. So osteomyelitis is an infection of the bone. It often occurs in stage 4 wounds when the bone is exposed. Osteomyelitis is not compatible with negative pressure therapy or e-stim, e-stim for wound healing. And therefore, if a person has osteomyelitis, it can restrict what type of interventions can be used to promote wound healing. And a pressure injury will not heal if there is active osteomyelitis happening in the wound bed. As with Spring's account, she had a long period of IV antibiotics, which is often the treatment for osteomyelitis, but the rate of recurrence typically is quite high if the wound is not closed. I'm sure many people have heard the term microclimate when working in the area of pressure injuries. Microclimate is the term, is the temperature, humidity, and airflow at the skin's surface. If these factors are not optimized, it can increase an individual's risk of developing a pressure injury or preventing a pressure injury from healing. So the microclimate is an important consideration both at the preventative stage and when providing individuals or providing interventions to an individual who has an active pressure injury. Okay, so next slide. This is a quick overview of the primary points of care for pressure injuries in the SCI population. So many different disciplines can influence the prevention and management of pressure injuries. I'm not going to go through each area because we're running a bit short on time. And then in the next slide, there's also other disciplines that are quite integral to the part of the care plan. Unfortunately, however, these services are not readily available in a lot of areas. So dietitian services and psychology or social work to help support behavioral change. Next slide, please. The takeaway from this is that it really is a team to work together to help the client heal from a pressure injury. So rarely one point of care will be sufficient for healing to occur. And unfortunately, as it sounds like was Spring's experience, the availability of all these different services varies significantly throughout the province, regardless of the care setting. So whether that be in the hospital, long-term care, or in the community, it's not uncommon for GF Strong, like I was saying, or VGH to have admissions from rural communities because there just is not the services available to support that individual with healing. And as I'm sure everyone's aware, specialized spinal cord injury medical and rehabilitation services in BC, unfortunately, is quite limited. So next slide, please. What does that mean for us as healthcare practitioners? One above, the one before that, guy with the hats. Oh, maybe you guys don't have this one, or maybe it's misplaced. Sorry, I may have made changes. Basically, it means that particularly as OTs and PTs, we often have to wear many hats when it comes to working with individuals who either have a pressure injury or who are at high risk of having a pressure injury. So this is a list just of the different areas that we can be involved in preventing and treating pressure injuries in the spine population. As you can see, it's quite a broad area. Next slide, please. So prevention is the key and hopefully is what we're aiming for. So during your initial sessions with a client who has a spinal cord injury, regardless of the reason for the referral, please take the time to review skin management practices with the client as part of your evaluation. Use the opportunity to ask questions about the client's pressure management strategies. This could include what their weight shifting practices are, skin checks, how do they do them? Do they have the equipment they need to visualize them? Are their caregivers educated? Do they need assistance with doing skin checks? Because it's actually quite difficult to do a thorough skin check on your own, regardless if you're injured or not, on your buttocks. Their equipment, maintenance, what types of transfers do they do? Is there a sling left underneath them? And as a therapist, if you are prescribing equipment, make sure you keep skin health in mind. For example, if you're prescribing a wheelchair cushion to a client that has a wound history, you want to be very careful about what type of cushion you consider to, as we know that skin that's been healed from a wound, after a wound, is always at higher risk for developing future wounds. Then there's activity and task optimization. You want to try and reduce the risk factors of pressure, shear, and friction and moisture when the client does their activities. For example, is shearing occurring when the client does their upper extremity strengthening exercises or intermittent catheters? Proper positioning. You want to make sure you educate the client to be aware of their positioning on their equipment and how they can sense if they are off position. So for example, in my own clinical practice, I've seen stage 4 pressure injuries that were caused by clients sitting on a cushion that was placed in the wheelchair backwards by the caregiver. And nobody ever has malicious intent. It is just that you don't know what you don't know. And so I really feel education is a really important aspect of preventing pressure injuries. Spasticity management, also through positioning, is an important consideration as well, to reduce that shear and friction that can occur. So the key at this stage, the prevention stage, is to provide interventions that keep skin health in mind, even if the client does not have an active pressure injury. This next slide is just an overview.
Sorry, Cynthia, sorry, I was just gonna interrupt you just to go back to the slide before, the slide that we had going on. James, are you able to pull that up? There we go. Cynthia, are you able to see that screen? The Slido poll with the word cloud. So the question was, what do you find is the biggest barrier to pressure injury care services in your area? And so what happens with this, of course, is that the more entries that we put in, they sort of get bigger and larger. And it's really, really obvious to me, looking at this poll for the attendees, that education and the lack of education seems to be a really constant theme in, I would say, the 4 largest ones that I see there. That lack of education impacts client care, right? Which is exactly why we're here today, providing this webinar, and when James and I travel around the province, always making sure that the pressure injury session is the first session that we talk about, because it is so preventable, and having that education, knowing what to look for, what the risk factors are, how to identify it, how to communicate with your colleagues, to make sure that everybody is aware and can respond in a timely fashion too, right? So having this education is key. And so happy to have such a large number of people here today, and recognizing that education is a challenge and educating yourselves. Thanks so much. And back to you, Cynthia.
Great. So these are some of the self-management practices that we teach both on the inpatient spine program as well as the outpatient spine program. And I should say that it's often not enough to give the person a handout or give them one session. and then assume that that's all that needs to be done. Quite often, the information needs to be provided repeatedly to initiate behavior change and to make sure the clients are aware of what the skin management practices, best skin management practices are for preventing a spinal cord injury. So there's a quick list of some of the basic ones that we talk to people about. Particularly for in the hospital, when people have adjustable beds, making sure that the knees are raised before they raise the head of the bed up is an important one to prevent sliding from happening, and which can cause a shear wound on the coccyx and sacrum. And then the head of the bed should be raised less than 30 degrees for long periods of time. So we understand that, especially in a hospital setting, people are going to be sitting upright when they're eating or when they're interacting with people, but that should really be limited to 20 to 30 minutes at a time. And then if they're in bed for longer durations and they're not totally flat, then keeping the head of the bed elevated less than 30 degrees is key to preventing skin issues. Next slide, please. Hospital-acquired pressure injuries. Unfortunately, it is not uncommon for people with spinal cord injury to develop pressure injuries when they are in the hospital. I've just done up a quick list of practices that could reduce the incidence of hospital-acquired pressure injuries. That being said, I'm fully aware that there are a lot of challenges in the hospital setting that can include lack of knowledge, frequent staff turnover, lack of access to appropriate equipment, and staffing shortages, just to name a few. In an ideal world, there would be protocols in place in emergency departments as well as on floors that admit spinal cord injuries, people with spinal cord injuries, to prevent pressure injuries from developing. And remember that it can only take hours for a wound to develop. So I've heard countless times, or I've worked with clients that developed a pressure injury when they were on a stretcher for 5 hours, 6 hours, waiting to get care in an emergency department. So what I talk to my clients about is having the person and their support team, caregivers or family members, that they really need to advocate for appropriate equipment and regular positional changes when they are admitted to hospital. And in our outpatient program, we talk to many clients about bringing their own overlays when they're transported in an ambulance or when they're on a bed in an emergency department. So it could be a ROHO cushion that they have, it could be a ROHO overlay, it could be an action gel pad, anything that helps reduce the pressure, particularly under their buttocks when they're lying on that stretcher. And for those of you that work in the hospital, I think there's quite a few participating today. Think about if there are any opportunities at your facility to work with policy or decision makers to include these practices into standards of care for SCI clients. One very tangible, cost-effective thing that could be done is putting up a note on or a poster in the client's room by their bed that talks about regular positional changes and skin management practices. Could be helpful at hopefully reducing hospital-acquired pressure injuries. Okay, I'm going to try and whip through the next several slides because I know we're running out of time. Okay, so we talked about trying to prevent a wound, but what do you do when you have a client who has a wound? Because often we as therapists or nurses aren't called in until there's already a problem, and usually it's beyond the stage 1 or stage 2 wound or pressure injury. So next slide. When this happens, you need to be a bit of a detective and identify the cause of the pressure injury as well as the contributing factors, because the pressure injury won't heal until the cause and contributing factors are addressed. So next slide, please. So here's just a list of some of the possible causes and the many possible contributing factors that can, so the cause is the why, and the contributing factors are those factors that are either preventing healing from occurring or making the pressure injury worse. So often for stage 2 pressure injuries are greater, multiple things need to change for healing to occur, and it's not enough to only address the cause. So next slide, please. One example of this is in this scenario, we have a sacral pressure injury. You can tell by the shape of the wound and the clearly defined edges that it is pressure that's the cause. So you identify the cause of the wound as the lower edge of the person's wheelchair backrest. You fix the cause, but the wound isn't healing. So consider all other potential contributing factors, which in this case was sleep position. So sleeping on their back, which is increased pressure on the wound, microclimate issues. So remember that airflow, the moisture issues, the temperature. Then on a memory foam mattress, again, that's pressure and microclimate issues. Smoking cannabis regularly for symptom management. So the science is not clear on this, but the physicians that I work with recommend people, if they're using cannabis products, people that they vape or ingest cannabis instead of smoking it when they have an active pressure injury. Because again, sometimes if tobacco at all is in the cannabis products, then it will restrict blood flow to the skin. Sweating due to autonomic dysreflexia, so which can often be caused when sitting or lying on a wound. So that comes back to the microclimate and moisture balance. And then, of course, dietary concerns. So this individual was not getting enough protein intake. And if you don't have enough protein intake when you have an active wound, sometimes that can be a primary issue that's preventing wound healing. So next slide, please. So let's move on to assessment. So there are lots of tools to assess a person's risk for developing a pressure injury. The most common ones that I'm aware of are the Braden scale and the SCIPUS. But I did a lit search as part of preparing for this presentation, and 29 different tools came up for the adult population to assess risk of developing a pressure injury. These tools can be helpful, but the majority of spinal cord injury clients will always score in the high risk category. There's also a pressure management assessment tool called the PMAT. I'm not sure if anyone's familiar with that, but it was developed in 2011 by an OT in Winnipeg, Jennifer Burt. So keeping it in Canada. The PMAT is not specific to spinal cord injury, but it's quite a good guide for evaluating risk and as well as evaluating pressure injuries when they've occurred. It's a 17-page assessment form, so it is very detailed. The assessment collects information on numerous different data points, including wound, positioning on surfaces, details of the equipment, the client's activities, transfers, self-management behaviors, risk factors, wound evaluation, and cognition. And then at the end of the form, there's a small section for the therapist to write in their summary and plan. In my personal opinion, the PMAT can be a very good tool for therapists who have a little bit less experience with assessing and providing interventions to SCI clients who have pressure injuries. So it could very well be worth checking it out. And the tool can be downloaded for free, which makes it very accessible. Next slide. So something that can be very helpful to do if a person has a pressure injury or you're trying to prevent them from developing a pressure injury is a 24-hour surface assessment. So this is an evaluation based on the premise that pressure management best practices should be applied into the functional context of an individual's life over the course of an entire day. So it's looking at all of their services and looking at their different tasks and activities and really applying pressure management practices to all of those different areas. So next slide. So the therapist, if you're going to do a 24-hour surface assessment, the therapist needs to understand the impact of each support surface on the client's stability, function, microclimate, shear, and friction. And then you need to correlate the pressure injury with the support surface during rest and activities. So I think that's a really important part right there, rest and activities, because I often will assess someone when they're just sitting in their wheelchair and they look like their pressure redistribution is great, their pressure map is great, there's no factors that jump out that are red flags to me. Then I'll go ask them to go wheel around for 5 or 10 minutes. They come back and I reassess their position, and it's quite different. It's quite a different presentation. So it's really important to not just see them when they're static, but also when people are doing their activities. So next slide, please. That goes on to the task and activity assessment. So here's the list of some tasks and activities that can be assessed. This is by no means a comprehensive list. And then when I do my assessments, I always get the most meaningful information when I actually observe the client doing an activity or a function, a task, ideally in their own environment. I cannot say enough about actually observing the person in their equipment, in their environment, doing their activities. Next slide, please. Here are some assessment tips that I'd like to share with you guys. Again, take a look at the wound. That will give you a lot of information that you wouldn't have otherwise. So it's been my experience that often the descriptive of the wound in a person's chart or on the referral can be vague or inaccurate. There are many, many times where I've been referred to assess a GT pressure injury, but it's actually turned out to be an I2 wound when I look at it. So whenever possible, do a joint appointment with a nurse so that you can visualize the wound without any dressings. And then also, you want to make sure that you have a full appreciation for the size of the wound, because the wound opening is often smaller than what the actual wound is. So it's really important to know the areas of undermining. I'll give you an example that I came across in my clinical practice. I had a person referred to me for a ride cushion because they had bilateral GT wounds and a coccyx wounds. The openings of the wounds were not extensive on the skin. However, when I did a wound evaluation with one of our nurses, the undermining of the wounds was extensive, and it would have been harmful for the person to sit on a ride cushion because the areas of undermining would have been contacting the firm surface of the cushion. So it's really important to make sure you know the areas of undermining of a wound, particularly if you're doing any interventions around equipment or positioning. Consider doing a bare skin assessment if you're evaluating the person's equipment in relation to the pressure injury. This can be particularly helpful if you are doing an evaluation of the person's position on a toilet or a commode seat, because often the wound makes contact with the edges of the commode seat or the toilet that you wouldn't necessarily think about if you were thinking of, say, for example, an IT wound. And then, like I said, assessing the client in their resting and functional positions is very important. Next slide. Visualizing the wound. It tells you a lot of information. The quick review, circular wounds with defined edges typically indicates pressure as the cause. Jagged edges indicate shear friction. Mottled or irritated skin indicates moisture, and necrotic tissue indicates that there's ongoing injury to the wound. Next slide, please. So some words of advice when doing the assessment. Establish rapport with the client before diving in, because you get very intimate and personal with the client when you are doing skin management interventions or pressure injury interventions. And so it's really important to establish rapport and put the client at as much ease as possible. Inform the client of the purpose of your involvement, what you're doing at the start of each session, and then throughout the sessions. And make sure to explain and get consent from the client before doing any manual handling. So for example, if you're going to do a ROHO inflation check, although that's a very common thing we do as practitioners, you have to think about it from the client's perspective. If you're doing the ROHO check properly, you are reaching underneath them, underneath their buttocks, and putting your hand deep into the wheelchair, which can be quite an uncomfortable situation for the client. So make sure you explain what you're doing and get consent from them. And then, of course, actively listen to the client. So they are the source of information, and you really need to make sure that you're listening to them. Okay, next slide, please. You've done your assessment, and now what to do with all that information, because it's a lot of information to take in. I'll move on to the next slide really quickly. There are some red flags that can point you in the right direction of where to start. So is the same area of skin breaking down repeatedly? Are there any incontinence or spasticity conditions? Is the pressure injury weight bearing throughout the day? Are the support surfaces in poor condition or need upgrading? Is there no clear schedule, repositioning schedule? Are skin checks being done frequently enough? Are the transfers safe? And is there loss of positioning throughout the day? So these are just red flags of a place where you can start. We're coming up to the end here, so a couple more slides, please. Clinical tidbits. If you are prescribing a ROHO cushion, please, please, please ensure that there is a plan for regularly monitoring the inflation properly. I can't tell you how many times I've worked with clients that have gotten a stage 4 pressure wound because the ROHO was not inflated properly. Funding is a big issue. If the person doesn't have funding for equipment, please try and explore not-for-profit organizations and think about outside the box to look for funding. IT and posterior DT wounds are rarely developed in a lying position. Clients with sitting-related pressure injuries often have postural and pelvic asymmetries. Forward leaning tends to be a more effective weight shift than a push-up. And people in manual tilt and space wheelchairs rarely get tilted frequently enough or far enough back to be effective pressure weight shifts. There's some more clinical tidbits here, but I know we're coming up to the end, so we'll just skip through to the next slide, please. Pressure mapping. I know there's a lot of questions around pressure mapping. I like pressure mapping. It can be a very useful tool for finding out information, but if you do not have access to a pressure map, it should not stop you from being able to assess an individual's pressure risks. So manual palpation in the area of the pressure injury or in the high-risk areas can be effective at assessing pressure. So please don't hold off on getting involved or intervening with a client thinking that you need to have a pressure map to do a good assessment. And lastly, some words of wisdom. The therapist can be the content expert, but the client is the expert of their body, especially with people who have had chronic SCIs. Medical recommendations are not always compatible with real life situations. So if a client is not implementing your recommendations or the team's recommendations, find out why. Question complete bed rest, because that can have lots of negative consequences as well. Be mindful of your documentation, choose your words carefully, and choose the right time to provide education to the client to make sure that the client takes in the information. And that, I'm sure you guys are tired of hearing me talk, but that's about it.
Awesome. Thank you so much, Cynthia. We don't have a whole lot of time for questions, but if you can stay, we can stay on for a little bit. I did just have one question for you, or actually it was from Heather Bromley, asking about recommendations of support surfaces with regards to what they can recommend in an acute care setting, what they can have on site. And if you have any recommendations, whether that's low air loss or.
There's several algorithms that are available online, and your hospital may actually have an algorithm. I know VCH has an algorithm for how to decide on support services, specifically mattresses. Quite often, The safest bet for someone who has a spinal cord injury and is unable to reposition themselves effectively, or has a pressure injury, dynamic air, so low air loss or alternating air tends to be the gold standard. The one caveat to that is you have to make sure that the person is properly suspended or immersed in all positions. So too often we will see people bottoming out when the head of the bed is raised, causing high areas of pressure.
Awesome. Thanks, Cynthia. Is there, Stephanie, you have a question? I think you're still muted, Steph.
Yeah, sorry. I had the computer closed. I was just reaching under my desk here. So my question was, you had mentioned an experience where you had your client had a pressure injury, and you were about to put them onto a ride cushion, and then you checked for undermining, and you found that that would make it be in contact. Was it like I'm just trying to picture the area. Was it like an area that you thought was initially going to be offloaded? Like it was a custom cushion, or?
Yeah, so the things with a ride cushion are where there's contact is high pressure, and where there's no contact, there's no pressure.
Mm-hmm.
So they can be very good for some wounds. And I do quite a few ride cushions for pressure injuries, and I know Shannon does as well. The concern with this client is their coccyx wound was the area of undermining was quite large. And so it would have extended into the area where they would weight bear on the back of the cushion.
Oh, I see. Okay, so for up the back then. Okay, thank you.
Yeah.
We'll check for that.
Mm-hmm. Pooja, do you have a question?
Yes, I have a question. So I wanted to know your thoughts about the spacer fabric slings, is it true that they can be left under clients? The universal slings that we use for transfers.
So my clinician brain says no, always remove the sling. But I know in some facilities, for staffing reasons, that can often be quite a challenge. So what I will say in that circumstance is it helpful to have a compromise? So maybe you keep the sling behind the person's back, but remove it from underneath their sitting surface, and make sure sitting surface, so underneath their buttocks, and position the sling so that there's not any wrinkles or anything or edges that the person is in contact with their sitting surface. There are some slings that the manufacturers say are meant or safe to be left underneath because they are more of a rectangular shape, and so there are no seams and no edges. But you also have to then consider what the person's sitting surface is. So if they're on a cushion that's meant to have some immersion, where they're supposed to sit down into it, so either that be a gel cushion or a Vicare cushion or a Rojo cushion, then any layer, particularly a sling, will prevent immersion from happening, which increases pressure. So again, I always advocate for people to have slings removed in facilities. If that is not feasible, then really looking about if they really need to be left in, then how can that be done as safe as possible? And then if the person has a wound on their buttocks or on their coccyx or sacrum, then I would always advocate to have the sling removed, regardless of what compromises can be made.
Yep. And I'll just add to that as well, possibly an opportunity for education on staff biomechanics as well, and different strategies and how to remove that sling so that it decreases the challenges on whoever's helping. Okay, we just did have, I was trying to look at these. Okay, so Stephanie already had your question. Ruth, you have a question.
Yes, so I work in an acute care setting And just wondering if you know of any guidelines around how, so say somebody has a stage 4 coccyx wound, how long they should be sitting up for, sort of best practices around mobilizing with those types of wounds.
So this is, I don't want to use the word controversial, but this is a big area of discussion. Physicians, there are some physicians that feel that if there's a stage 4 wound, the person should be on bed rest full stop. I like to take a little bit more of a clinical approach to it, in that can the person be seated safely, with ideally offloading the wound. So sometimes that's not possible in acute care setting because you only have them usually for a moment at a time, and your focus is not on optimizing the person's individual equipment. I will say that I worked on this spine wound clinic for many years, and even with the stage 4 pressure injury, if the person's seating could be optimized as best as possible, so even if that's a ROHO with proper inflation, then the recommendation was 2 hours in the morning up, 2 hours in the evening up. So that is with a chronic stage 4 wound, where the goal is still to heal the wound, or they're waiting for flap surgery. If the person has had a flap, or if there's a physician who has differing opinions, then of course that's a different circumstance. But generally speaking, it's the 2 hours in the morning and 2 hours in the evening, provided that that sitting time does not cause deterioration in the wound.
Okay, thank you.
Also, just to add to that, to what Cynthia talked about, like being investigator, detective, like finding out what it's caused from, because if you've got a coccyx wound and that was caused from the mattress or from bed, right, really understanding what was the origin of the wound and what is the best practice and what's going to be best for that individual, dependent upon their equipment and lifestyle factors. I'm just reading through some of the questions here. Okay, Amber, offering, so as far as the consistent, about offering to use the client's phone as the consistent point of, when we have different caregivers providing assessment and recommendations and treatment of one wound, then it is really important to have one consistent set of eyes. And I always suggest that's the individual who has the pressure injury, so that they're most aware of that. But if it's not them, then someone close to them that are most aware and seeing that change over time, and having it time stamped on your phone. I love that idea. It's fantastic. So last webinar, your presenters discussed the suggestion of max inflate when the head of bed is up. Any recommendations regarding this approach? Cynthia, did you want to add anything? I realized you weren't at the last, but with regards to max inflate for the head of bed?
I mean, the concern about that is if they're sitting with max inflate for long periods of time with the head of the bed raised. I am not aware of what was talked about in the last session, so I don't want to cause confusion or contradict anything. My clinical thoughts are, if you're doing that for periods of 10 minutes, that's probably a safe practice. But I think you really want to assess the inflation for when the person is in that position. So if a person's immersion in a mattress or in a cushion will depend on a variety of factors, including their weight, their shape, and so in their position on the equipment, where they're positioned on the equipment. So I hate to say a blanket statement of max inflation when they're with the head of the bed raised, because that might not be the best for that individual client. So I think it really does take assessing each individual person in the different positions with the inflation to know what works for that person.
Absolutely. And to add to that as well, it depends on the mattress. too. So what can happen is if you have the long baffles, and it's not on max inflate, when you bring it up, then you could decrease or increase the pressure in that area so that the air displaces. Another time that happens a lot is if it's in a wider mattress. So if you do have a double or king size air mattress, the baffles can just have that much more space to separate. So yeah, totally agree. Assess each situation as it comes. Okay. Are there any other questions? Thanks to the group of you for sticking around a few extra minutes. Thank you so much, Cynthia, for sharing your knowledge. Thank you, Spring, as always, for sharing your lived experience. It's so valuable for us. Please join us for the next session. Our next webinar is scheduled for May 1st, 1 to 2 p.m. and the topic is going to be spasticity management. Thanks so much. We'll see you guys next time. Bye.